Okay, are we ready? Okay, I'll just introduce briefly also Professor Jean-Marie Annoni with a nice
Thank you very much for all this very interesting talk. My name is Jean-Marie Annoni. I'm a neurologist here at the hospital and University of Fribourg. And we had this very interesting presentation of the genotypic modeling in stroke system by Dr. Nachev, this population-based data epidemiology to facilitate the health promotion by Dr. Bochud and by Dr. Draganski, this study, this large state study, brain studies. And this is bringing very important points. I would start with first question. How do you think, I will take my position of clinician, you know, I see patients with dementia, and at the end I tell them you have this or this, and I tell them it's probably related to this problem, and I say in order to prevent mostly what you have to be careful to take some exercises, to do some cardiovascular to take care of the cardiovascular problems and so on. And how could I integrate better this data in the clinical life? This is the first question maybe that I could ask to the panel. Maybe Dr. Bochud, Professor Bochud, could you think if how we could use better the epidemiological data, at least at the clinical level?
So at the clinical level, I think what is, of course, the disease is already there. Then you are at the level of what we call tertiary prevention, that is trying to minimize the impact of the disease and to maximize longevity and quality of life of the patients. Then, of course, these are different, in my view, different types of data that need to be used for that. Clearly, what I've been talking about were data that are collected well before disease onset. But I think that it is important to show the patients where they are located in terms of risk profile, and maybe as a motivation for them to have a healthy lifestyle, because we do know also in the tertiary prevention domain that keeping a regular physical activity and healthy diet are also useful. So clearly those recommendations that are normally done with a health promotion purpose can also have some clinical utility in tertiary prevention. But clearly, I think to me the primary usefulness of those population-based data are within the settings of health promotion and primordial prevention, if you will.
Can I just ask something, because I think this is crucial now also for our audience and what we are aiming at. I'll use this description what Paraschkev used maybe in another context is hospital embedded. And I'll be also interested indeed how this knowledge that we are creating maybe outside can be linked to what Paraschkev is talking about. How can we integrate all this information where physiotherapists, ergotherapists are going outside to some either bedridden patients or not, at home, doing some interventions? How can we integrate everything what's happening in the hospital and outside of the hospital to create new knowledge that again comes back to us clinicians for the good of the patients? Paraschkev, what do you think about this?
Well, I think that the critical question is what will actually be the delivery infrastructure. So what system under what governance and also with what funding could all of this be achieved? And it seems to me that because we need such outrageous scale, these need to be initiatives that either go via government or via healthcare, and they have to become embedded in what would otherwise have happened anyway. So yes, of course, we should be connecting what happens in the community with what happens in hospitals. Vertical integration, of course, is one of the primary challenges of healthcare. In the UK, of course, you have this artificial split between primary care and secondary care, with very poor links between it. And I think the only way to achieve this is if there is a unified system. It doesn't have to be the same system, but it has to be a system where components can talk to each other. That's what I mean by unification here. That gives us continuity across those domains. And then, of course, the apparatus in order to produce models that can look at all of that data jointly. There are, of course, ways of doing this that preserve privacy, which is so important in this realm and must be essential. But it really seems to me that it's the kind of thing that, in order to deliver it at the scale we need, it has to have government level backing, and it has to be integrated within conventional practice, within current practice, whether clinical, rehabilitatory, or outside it. It seems to me that the paradigm for too long has been you do clinical work or rehabilitation work or whatever, you do something with a patient for service, and then you do something separately for research. The two seems to me have to be brought together. And if we are going to be doing things outside hospitals, then it would be great to bring them under that rubric. So for example, that a population level study may be mandated for the purposes of better healthcare. I mean, I'd love to do the studies that you're doing on everyone, and that should be part of healthcare. It should be said, look, if you want us to look after your brain, then you need to have an MRI when you're 18 or 20 or whatever, so we can have a baseline, or 25 or 35, etc. So I think it's really how we solve it at the structural level that seems to be most important.
Maybe another comment. I think that electronic patient file, electronic health record, may be one way to go in the sense of having a tool that allows following trajectories of people regardless of where they are taken care of, whether hospital, whether primary care, whether before getting into the healthcare system, and where also exposures can be assessed and collected, and that people can choose whether they are willing to share, selected data for a given purpose. And also that could be a tool for the clinician to know, what type of exposures this specific patient has been, exposed to lifelong, and to help him make proper decisions.
Oh, but I cannot agree more. Nachev has some beautiful studies on this clinical narrative, how rich it is, just by looking, what was it, radiological reports, Nachev? I mean, it's amazing how much information we have there. But again, it's a question of a political decision, because here, at least in Switzerland, we had this discussion about the electronic health records, what type of information is coming in. Again, privacy issues. Can the patient by himself, by herself, also hide particular type of data? Endless story. Right.
Well, perhaps one of the problems is the way in which this is justified. You see, if we approach it as primarily a scientific problem, if we say, look, we would like to know more about the brain, then suddenly it appears to be something that we are taking from patients for more or less our own benefit, or even worse, curiosity. Whereas in fact, this is very different. This has to be motivated from a therapeutic angle right at the start. Not we may be able to derive some insights that will then eventually help us, but no, actually doing these sorts of studies will help us now. And also the pooling data, or at least finding ways of analyzing data without pooling, ways of integrating intelligence across multiple individuals, that has to be part of the service and part of the service contract. Any healthcare system implies a kind of contract where the patient is treated within something that is inevitably distributed and draws value from each individual participant. even in systems that are not centrally funded in the way that the UK National Health Service is. I think that contractual obligation to help others in participating within the system is there. So I think the justification can be made, it just has to be done in the right way, and I think it has to be done quite forcefully, because for as long as we remain blind to the bigger picture, it's going to be very difficult for us to provide the best treatment for individuals, which is what our duty is and which is what patients ask of us.
Do you think we should, if we want to push for a larger registry system, for example, we are talking about the brain here, should we implicate more population and patients? I mean, our research studies, our projects are not done with the patient. Now with this PPI system, which is now with population and patients' participation, would that be a way to improve national integration in towards possible registries, for example, in this case?
Yeah, I do think that's an important aspect, because also in terms of utility and motivation, that if it takes into account what people want and what is of interest to them, I think that there is a higher probability that they will participate and to have a broad, a large number of people from which high quality data can be gathered and compared. So I think that this participative component is important also because, people may have different views on what they want that researchers, because I think we may not, know quite clearly what some part of the population would like to receive as a service for their own benefit. So I think those participative components are quite key. And now more and more, this is being integrated into projects in terms of focus groups, having mixed method, that is, you integrate classical quantitative methods with qualitative methods from the social sciences. So we do this more and more in our studies in public health, where we try to integrate the opinion of participants also already at the design stage of the study.
But I suppose the question is, how would participation in a registry be encouraged? If it's something like UK Biobank, then whoever's curious or interested or whatever might do it. But it means that inevitably there's going to be a bias to those who have an interest in health. And it seems to me that rather than doing it that way, it would be better to, for example, offer a health check. So the way, I must say, I would do it if I ran a health system across the entire country, I would say, look, everyone is offered a health check at the age of whatever. And then at that health check, you draw all the investigations that you need for the study. But at the same time, you report the result to the patient there and then. Now, that's not a patient, of course, because it's somebody who's healthy, but it establishes a baseline from which you can compute trajectories and so on. But you're embedded within the healthcare system so that then you have the right kind of engagement, so that this isn't something that people do out of the goodness of their heart or out of curiosity, but it's something that they see as part of their healthcare. And also they begin to understand that healthcare is not about what you do when you're ill. It is about what you do so that you do not fall ill. Prevention is obviously not something that we think about in our daily lives. We only really think reactively about what to do when we fall ill. But this is something that we can encourage, and we can then enable scale, I think, much more effectively.
I think one of the key aspects that could motivate people is to say, okay, look, if you do these, regular checkups, you get a discount on your health insurance premium. And that has been done already. That exists, but for instance, the difficulty in Switzerland is that we have over 50 different healthcare insurances, with different rules, different organizations, and different decisions. So it's difficult to get something really homogeneous across the entire country. But I think those type of economic incentives could be a way to go.
I would love to come back again to the clinical reality, because all of us we are clinicians. We're interested in getting this knowledge back to the patient and to us. What in realistic terms you think can be the way how the knowledge that we are already accumulating, let's say, outside with our research or epidemiological studies and so on, what actually Jean-Marie also asked at the beginning, how can this come back to the clinicians? And do we need also a cultural shift there? Because I'll give you a little bit out of this context example. Here we're using a tool by one of the MRI scanner vendors that is estimating local volumes in different brain regions. They are compared to a certain normative database, and it's telling you your left hippocampus has a lower volume than the aged individuals, the individuals at the same age, and so on. And sometimes I see this number, but I say, well, I think here the quality was not good, and this type of automatic discovery of this region is maybe not okay. I don't trust this result. Sometimes when it fits to my clinical diagnosis, I say, yes, great tool. How, in a larger sense, can we bring this back to clinicians to give them also the incentive to also donate, what also Jean-Marie asked at the beginning, their everyday clinical not only data, but also experience, because the best way of doing this machine learning is to link it to expert opinion, not only doctors, but also nurses and ergo, physios, etc. Are we ready for this, we clinicians? What do you think? I mean, I don't know, maybe Parashkev, you can start, then Muriel.
Yeah, I mean, I think it seems to me that this doesn't require any exceptionalism. We can merely extend what we do already. Yes, of course, we rely on our clinical experience, but we also look at evidence, and we take evidence as being the outcomes of studies where patients with a particular range of conditions are modeled that happen to fall within the target of the patient in front of us. But moving beyond that kind of cohort population-based analysis, it seems to me that we can make exactly the same use of a model that produces an individual level prediction. And provided that that prediction is sufficiently corroborated by performance across a wide range of patients, and in particular shown to generalize well, provided there is some kind of reassurance about its certainty, so that it should be probabilistic, I think we would start to use that information. And then if it so happens that this model is so complex that we can't understand how it arrives at that prediction, we would nonetheless treat it as being, if you like, the best synthesis of the available data. That's what a model really represents.
Mm-hmm.
And we rely on it as a kind of oracle because that is all that we have. Now, of course, all of these models will always be overridden by clinical judgment. They have to be, because we're the best neural network that there will ever be, right? We cannot create brains that are cleverer than our own. That would be an infinite regress, right? But the advantage of the machines is they don't get bored. Provided they're working properly, they can be relied to be reproducible. And of course, they're limitless in the amount of data they can potentially, or at least practically limitless in the amount of data they could potentially ingest. So I would merely say that we should extend the existing paradigm, but make some adjustments for the nature of the models that we'll increasingly be using, where essentially we're comparing each patient to a neighborhood of patients like him or her.
Thank you. Muriel, what do you think now?
So maybe I'm not a clinician anymore because I'm a public health physician. So my unit of interest is the population. So it's not. I've done quite some clinical work a long time ago, but nevertheless, the thinking is there. And so maybe one reflection. I think what we can bring to the clinicians is, if we really can put the funding into it, is a real-time synthesis of knowledge. That is, there is so much information being produced on a daily basis nowadays that it's impossible for any given clinician, irrespective of his specialty, to have an accurate synthesis of the knowledge. So if we can bring to physicians a tool that is able to really provide the best available information on any given day, of course, there will be some delay, but let's say a reasonable update, then I think it can be a true benefit for the clinician. And then maybe also we can say, if you contribute to that knowledge, if you also provide information to enrich that knowledge, then you can also benefit from it in return. And then maybe what I can see as a benefit for patients and their clinicians is to get to what I call a better riskometer, a type of how do I know my own risk? It's by comparing my own data with the data of many, many other people. And it's by this big number that you can really get to a better prediction at the individual level.
Mm-hmm.
Otherwise, with our classical tool, we are not able to do.
Mm-hmm.
One interesting point also is how could I access and understand better these models in my everyday life? For example, Dr. Nachev models on white matter, for example. Very interesting, but probably if I would have to integrate that more in my everyday life, I should be able to bring my data in this model in connection with the specialist and try to understand what do they bring to my patients. And this is possibly so. We talked before of patients' participations, but also clinicians' participation, active participation would be quite interesting. And this can be only done, as you said before, can be done at individual level, but can better be done at, I would say, political or at least at the healthcare level. So to incent the clinicians also to participate to these registries and also to take profit of that, maybe, I don't know, maybe also in the publication or in these kind of things. Mm-hmm.
Nachev, what do you think?
Well, perhaps the paradigm here is actually the way in which clinicians themselves share expertise. So you might visit an institution and then demonstrate your practice and try to harmonize your practice with that of someone else, or perhaps a set of clinicians may sit together and arrive at a consensus about how to manage a particular disorder. Each of these things are possible in the realm of machine learning. One can produce consensus outputs of models, where an array of models is essentially brought together. One can fine-tune models locally to a specific population and also adjust them to a particular clinical practice and so on. So I suppose the way in which one might produce that kind of local aspect and to engage the clinician as well as the patient would be to emphasize the way in which these models are actually infinitely flexible, because they're not static. It's not like conventional statistics when you arrive at a p-value and then you forget about it. These are flexible things that continue to learn, and they get better and better. And what we have to realize is that everything here is always going to be asymptotic, because you will never know. You can never know what is best for a given patient, because that patient has never existed before. So that answer is analytically intractable. It always will be. And so you have to arrive at the best approximation. That best approximation will be dependent on how well you can define the neighborhood. And there's no such thing as a perfect definition of a patient's neighborhood. So all the models they're all going to be bad, but they'll just be a little bit better. We just need to get them closer and closer to that asymptote. And so a clinician will know that investing his experience, because of course, his or her experience, because of course there will often be part of the label that will determine how the algorithm is trained, will then allow that intelligence to be crystallized within the model that is then clinically applied. And so the clinician's intelligence then becomes embedded in the artificial intelligence with it, which ought, I think, to be satisfying, certainly if it improves the outcome of the patient, which is, of course, always our aim.
Should we integrate? Oh, sorry.
No, I just wanted, sorry, Jean-Marie, I just wondered, what is your prediction, both you, Muriel, and Parashkev, when will this come? If we have a sort of crystal ball, because Muriel was talking about these highways between the universities where the Swiss government decided to invest a lot of money. We are talking about unification of coding systems, etc., etc. And also this type of knowledge, what you're deriving about the functional anatomy of white matter. If I want to use it, of course, I can pull the paper, read it, and then interpolate in my brain locations of my individual patient who has also a lesion there somewhere. But when will this come, that we can indeed embed this knowledge and generate knowledge in our hospitals? What do you think, Muriel? Predictions?
Well, you know, Bogdan, it took 2 years to put in place the data sharing agreements and the legal aspects and ethical aspects. Just to show you that I think the biggest barriers are not technical. I don't think so. They are due to human rules and, you know, politics and legal aspects and ethical aspects. I think these are the number one barriers. The thing I like very much within the SPHN initiative is that the social, ethical, and legal aspects are being given resources, quite substantial resources, and I think that is very important. Otherwise, if we only invest on you know, technical aspects, I think it is going to fail. So it takes time. I know it is slow, it is frustrating, but I think we are much further away now, ahead than we were a couple of years before. But I've been personally very...
I think we have to, we're finishing to the panel discussion.
Oh, they are rude, these people. Okay, well, who's going to wrap up? Jean-Marie. Oh,
and say and thank you all the participants, the attendees, for their questions, eventual questions.
Thank you very much, all of you. Muriel, Parashkev, Jean-Marie. See you in half an hour after the break. Bye-bye.